important. So synthesis is an important aspect. And we know that depending upon the hormone action, the body will decide whether you will need to have an immediate effect or whether you can have a gradual production as well. So for things where you have acute control which is required, you need immediate processing of hormones in the form of calcium, glucose, volume, and salt, because you can't wait there to allow for hypocalcemia, hyponatremia, or hypoglycemia to happen. So these hormones should be immediately readily available for action. While for bone growth, puberty, reproduction, you want hormones which can be produced at a gradual state. So regulation, whether it is at the level of synthesis or release, will depend upon, one, the type of hormone. Will also depend upon what do you need in terms of the regulation and when do you want those hormones to start acting in that perspective. So often we have got precursor molecules, and these precursor molecules are broken down to different molecules, and this is classical of different peptide hormones, and that's why they take a long time to produce. One of the most classical examples in that regards is the pro-opio-melanocortin pathway, which is basically responsible for production of ACTH, and what else is produced via the POMC? And so there are three major parts. So if you look at the pro-opio, so that will be the endorphin, melanocortin will be the MSH. So this is basically a combination of MSH, ACTH, as well as endorphin, which are there. So this is basically produced at the level of a stress response, which will be there in that regards. You will get that. So from here, you've got MSH, which acts on the MC receptor to cause pigmentation and regulation of appetite. You've got ACTH, which is acting on the MC2 receptor to control cortisol, and you've got the endorphin, which acts on the endorphin receptor to cause, in a way, analgesia and opioid-like action. So what role will that happen in a stress situation? If somebody is stressed, your entire POMC becomes more. How will it help to cope your stress?
During stress, our appetite goes down.
Yeah. So during acute stress, basically you will eat more during chronic stress because your cortisol is high. But when you are faced with an emergency, you want a sort of a satiety to be there, so you don't get hungry. So that's why, as you rightly said, we have got the MC4 receptor which will start acting. Of course, cortisol. And what will endorphin do?
At the time, generally don't feel pain at the
Yeah.
Initially, but later on.
So this is the basis of that. Now, from this perspective, if you think of a condition, if there's a chronic stress, what is going to happen in terms of your endorphin levels will be high. Now, this endorphin, what is the effect of endorphins on GnRH? So it decreases the pulsatility of GnRH. So basically, in a way, if somebody has long stress situations, of course, there will be effect in terms of ovulation, in terms of the gonadotropin activity, and you will go in a shell. So basically, from a LH predominant state with more frequent pulses, you will go into a FSH predominant state, which that's why we quote unquote we say hypothalamic amenorrhea. So now the synthesis forms the basis of multiple disorders. So now we know there is a stepwise process through which this conversion happens. If you have a POMC defect, what will be the clinical manifestations you will have? So you will have issues in terms of pigmentation, in terms of red hairs, yeah? Yes? So you will have obesity with central hypocortisolism. So you will have ACTH deficiency with obesity, and along with that you will have depigmentation. This will be the effect of POMC. Now, as we have discussed that there are multiple ways in which this is cleaved. So there are multiple enzymes which play a role here, and that also gives you an indication in terms of pathophysiology. So you have got the proconvertase, which is responsible for conversion of POMC, as well as conversion of AVP, pre-pro AVP, along with conversion of insulin. So what will happen if you have a proconvertase defect? So you will have diabetes mellitus, diabetes insipidus, cortisol deficiency, and obesity, which will be the typical scenario in this perspective. So clearly, if you understand the overall synthesis and processing, you will understand the various pathophysiology in that regards, in that perspective. So you have a 6-year-old boy with weight gain and hyperphagia. Weight is already 32. The height is reasonable. There is lethargy and weakness. Cortisol level is low, and despite giving ACTH, the level went up to 200 nanomoles per liter. So there is a cortisol deficiency. Now, there is a sort of a mildly elevated blood sugars. So what are you thinking of in this perspective? Yeah. So we don't know at the moment central or peripheral, but yeah. Yeah, so we have to think of other possibilities in that regard. So if you have a PC1 defect, you will have a combination of GnRH deficiency, diabetes, as well as diabetes insipidus may also happen in that perspective. Now, insulin is another important hormone which is there in terms of overall synthesis, and we already discussed that it is also a pre-pro. So if we talk about whether we talk about GnRH, it is also pre-pro GnRH. We talk about AVP, it's also pre-pro AVP, pro-opiomelanocortin we have talked about, and insulin also is produced as a pre-pro insulin. And from there, via proteolysis, we have got conversion into alpha A and B chains and the C peptide, which is being connected to them, which forms a proinsulin, which is converted into proconvertase into insulin. And then you have the C peptide, which is a marker, the biomarker as far as the production of insulin is concerned. So in this regards, we know that when you are having insulin in the body, it is stored in the vesicle, and whenever it is produced, every single mole of insulin is associated with a single mole of C peptide. Now, why do we prefer C peptide over insulin as far as assessment of insulin is concerned? So levels are more robust, and insulin is more of a labile hormone. C-peptide is less labile, so it's a preferred mode in that perspective. So Alapan, 18-year-old girl with increased urine output, you have got hyperglycemia, the HbA1c is also on the higher side, ketone levels are on the lower side. So it's a non-ketotic hyperglycemia. She is lean and does not have acanthosis. So now 18-year-old girl who is non-ketotic and lean. So what type of diabetes are we looking at?
That be a case of type 2 diabetes for movie, but I think this BMI of 60 forms are much.
You have to think of MODY as a possibility because type 2 becomes extremely unlikely. But of course, you cannot rule out type 1 at this moment. Now, this was labeled as type 1 diabetes and started on insulin with recurrent hypoglycemias. Now, if you go by your algorithm and logic, it will clearly suggest that if we have a very low insulin requirement and you have a lean pubertal individual, you have to think of a monogenic form of diabetes in this perspective. And we found that the child was GAD negative. And here we found that there was a problem in terms of synthesis of insulin in the form of a HNF1 alpha, which is a transcription factor MODY. Now, when we talk about MODY, there are two broad type of MODYs. One is the transcription factor MODY, and the other is glucokinase or the sensitivity factor MODY. So what is the basic difference in their pathophysiology and clinical features? So this is one we are talking about where your transcription factor is not there.
Even from the initial point, but in the glucokinase and the insulin is not released at a certain threshold of glucose. After that, the insulin synthesis or release starts. That is the basic.
And what will be the impact in terms of the blood sugars?
So, in case of this glucokinase or glucose sensitive, the postprandial blood sugar, they'll not be very high. Because insulin is there to control the blood sugar, so there will be increase of less than 80.
So if you have a transcription factor MODY, basically your insulin is not being produced. So you will have deficiency, you will have both fasting as well as post-meal hyperglycemia. And maybe the first problem will be in the first phase response. So you will have more of a increment which happens after somebody is taking a meal. While if you have a glucokinase MODY, in that perspective, the body's sensing is effective. You are able to produce insulin, but you're not sensing glucose levels. So at a lower level, you will not produce insulin. So your fasting levels will go up. But if the sugar levels go above a particular level, you will have then production of insulin, which will then control. So this delta, as you very nicely said, will be less than 4 millimoles per liter or around 72 milligrams per DL. So this is a basic difference, and therefore you can understand based upon what the synthesis will have an impact in that regards. You have a 4-month-old boy with failure to thrive who has hyperglycemia with mild ketosis. Weight is 3.2 kgs and he is not gaining weight. Of course, at 4 months is only 3.2. C-peptide is low. So what are you looking at? Hmm? Hmm.
Peptide is low and the child has
Yeah. Mm-hmm.
So probably pancreatic any defect that causes this.
So you have to think of decreased insulin synthesis. Now, this could be a problem which is there in the whole of pancreas, or this could be predominantly in the beta cells. Now, what is the most common cause presenting at this age group? Yes. So if you think about overall causes of neonatal diabetes, you will say, okay, there are 50%, 40 to 50% are transient and 40 to 50% are more of permanent. The transient diabetes presents much earlier with less chances of ketosis, with a more severe disease, and they tend to resolve by 3 to 6 months. So this is unlikely to be a transient form. It is more likely to be a permanent form, and in permanent, mostly the synthetic defect because of the potassium ATP channel. Now, when we talk about transcription factor MODIs versus the potassium ATP channel, what is the basic difference in those scenarios? So we talked about last time you discussed about transcription factor MODI versus glucokinase, where one is sensing problem. When you are able to sense, you will be able to deliver the insulin. Now we're talking about transcription factor where your HNF1 alpha, 4 alpha is defective versus a scenario like this where you have a potassium ATP channel defect where your sensing of the ATP is defective. What is the difference between the diabetes in these two scenarios? So yeah, so what I'm trying to say is that transcription factor MODI, your basic machinery to produce insulin is not there, your gene is not there. So yeah, so insulin will not be produced, while here the problem is more of the sensing of ATP. So if your levels become very high, you may be able to sense it, and you will have benefit in terms of fusing of sulfonylurea, wherein you will have a beneficial response in that regards. Would sulfonylurea act also on transcription factor MODIs like HNF1 alpha and 4 alpha? Mostly yes. So they are exquisitively sensitive. That's what the point I also was wanting to bring up, is that these forms are very, very sensitive to sulfonylurea. While when we talk about potassium ATP, what is their sensitivity? Yes. So the dose requirement of potassium ATP defect of sulfonylurea is much higher even compared to the adult type 2 diabetes. So you may require glibenclamide at around 5 milligrams 3 times a day. While if you talk about somebody who has a HNF1 alpha or 4 alpha, you may even give 2.5 milligram of glibenclamide and you may develop hypoglycemia. So there is a difference in this perspective from that regards. So AVP we discussed about. So we discussed about POMC, we talked about insulin, and now AVP. So AVP is also pre-pro AVP. From where you produce the vasopressin, the neurophysin, and copeptin. Copeptin, unlike C-peptide, it's a marker of AVP production, and because AVP has a very, very short half-life, you cannot measure AVP in the circulation. You measure the copeptin level in that regards, and this is how you will produce. Now, AVP is one hormone you can actually see on the imaging. So when you are looking at the posterior pituitary bright spot, it's actually the vasopressin which is present in the granule. So it's a very interesting thing. You're looking at a particular chemical which is there. So posterior pituitary bright spot suggests that you have got a stored AVP. Now, if you have absent posterior pituitary bright spot, it helps you in differentiating between central versus nephrogenic DI. So in central, you have got no AVP, but in nephrogenic, you got lots of AVP. So will nephrogenic DI have the bright spot or not? Yes, that's the point. So you cannot use it to distinguish between central versus nephrogenic, because in nephrogenic all your store is used out. So that's why you will have an absent bright spot. So absent bright spot is a marker of diabetes insipidus, but not a pointer to central versus nephrogenic in this regards. So this is where you will store it. Now, if you have a problem of vasopressin synthesis, Vibha, versus vasopressin resistance, which one of that tends to present a bit early? Genetic cause of AVP synthesis versus AVP action, which is more likely to present in a younger age group. Resistance. Why does deficiency present a bit later?
It takes time to get this.
Yes, the very important point that you mentioned, that if you have a malformation, then your overall hypothalamus filtry may be damaged, like septo-optic dysplasia. That child may present to you within a newborn period as well. But if you talk about isolated AVP deficiency, they would be very, very unlikely in the first 2 years of life. So if you have a typical male child who presents to you with dehydration, fever, hypernatremia, low urinary osmolality, you're talking mostly about the V2 receptor defect, the X-linked nephrogenic TI. The reason, as you discussed, is like this case, 5-year-old boy with weight is 15 kg, polyuria from 2 years of age, urinary osmolality is low, and water deprivation test did not result in a rise. But when you gave them vasopressin, it increased. So this is more like a central DI. Now, first of all, what is the most common possibility at 5 years of age with central diabetes insipidus? Yes, so histiocytosis, of course, will become very important. So you will like to really look into in terms of the ear discharge, seborrhea, hepatosplenomegaly. But here, AVP response was there, and this was turned out to be a neurophysin defect. Now, why does neurophysin defect result in a two-hit model?
So initially there is a formation of defective neurophysin, that accumulation of those infected neurophysin causes further disruptions.
Yes. So neurophysin is not just a associated protein. It has got a very, very important role. It allows the vasopressin to be folded properly in the vesicle. So if suppose your neurophysin is defective, your AVP may not be folded properly, and the vesicles, it will just go into the cell and it will destroy those cells. So you will have first hit, which is because of partial AVP deficiency, but the second hit will be because of the damage. So that's why it tends to present you typically around 2 to 3 years subsequently. So it is a late presentation in that regards. Now, another hormone which is there, which is synthesized and stored. So as I said, there are very few hormones which are stored for a long time. Now, which are the hormones which are stored for a long time? One, of course, is thyroid. I'm talking here. Second, we discussed just now. Yes, what else? Insulin is not stored for ages. Like insulin, if you remember, there is always a sort of a biphasic pattern. The initial phase is the release of pre-formed insulin. But then after some time that goes off. Then you have the second phase, which is the newly synthesized hormone. So which is the other hormone which is stored in the body? Not to a great extent. Means you will be store it for some time. Suppose you need some emergency, you will say, okay, I'll store this much amount of PTH, but you will not store this much. Like thyroid is stored for 2 months, 3 months. AVP is stored for 15 days, 20 days. Which other? You can think of it. So body will store a hormone which may be not easy to form and you're dependent outside. So why is thyroid stored? So if your iodine is deficient, body wants to store it for a longer period from that perspective. So what other thing may become deficient in your diet or some other thing which body cannot produce? So epinephrine you will store in huge amounts. So which hormone is there which plants can produce? And vitamin D. So even we can produce. But you may have periods in which sun exposure is less. So vitamin D is the third hormone which is stored at a large extent in the fat. So you need to understand about the overall pathophysiology to get that point. Now, when you talk about thyroid, thyroid is stored for at least 2 to 3 months. because you never know when you will need it, and your metabolic activity becomes more, you need it more during cold weather, and iodine deficiency will be there. So this process of overall development involves multiple steps. And when we talked about congenital hypothyroidism, we said that you may have a problem either in the TSH receptor or the JNAS1 problem in the sodium iodine synporter, which transports iodine inside in the pendrin or thyroxine peroxidase, thyroglobulin, deox-2 or dehalogenase, and all these problems will result in synthetic defects. So one of the common endocrine disorder associated with synthetic defect is, of course, dysharmonogenesis from that perspective, and that becomes important. The other thing to remember is that if you have a large store, you will also have a risk of hyper, or you can say excess of that particular hormone. So if you remember thyroid, if you have a damage, you will have thyrotoxicosis. If you have a damage of AVP, when you do a surgery, AVP is released, you develop hyponatremia. Vitamin D, if you have too much, you have hypercalcemia. So it's only these three major hormones which you can store a lot, you will have a risk of hypercalcemia. The other excess production is that you produce immediately, like GH you are producing continuously, then you will have a problem. So that becomes important. So now you have a 3-year-old girl diagnosed at 2 weeks with congenital hypothyroidism, reasonably well controlled, but now presents to you with speech delay and hearing abnormality. Now, parents were told that, okay, everything is going fine, but now the speech is delayed despite your good thyroid control throughout this period. So what are you possibly going to consider here? Yes. Yeah, so anyway, any patient who has hypothyroidism, be it dysharmonogenesis, dysgenesis, you should do a screening here, BERA and all those things. But in this scenario, a possibility of Pendred syndrome should definitely be considered. Now, if we talk about synthesis, another important hormone which is regulated the level of synthesis, and a lot of its defects are because of synthetic defects, is cortisol. Now, we know that cortisol is basically produced using cholesterol. Now, whether it's all steroid hormones, be it cortisol, aldosterone, estrogen, testosterone, they're produced using the cholesterol. And cholesterol in the cells can come via the LDL receptor, or they can themselves produce a certain amount of cholesterol also via the HDL receptor. So when we talk about adrenal pathophysiology, we talk about NR5A1 and DAX1 opposing the HDL uptake. So that becomes important. Now, this cholesterol has to be pushed into the mitochondria for the subsequent process, and this is the crucial enzyme regulated process, the first process which is regulated, which pushes the cholesterol, the speed of cholesterol and the subsequent synthesis become more via the steroidogenic acute reactionary protein. Now, STAR is regulated via ACTH, via LH in the testes, and different hormones depending upon the particular site of steroid production, including angiotensin 2 for aldosterone for that matter. So cholesterol in normal scenario will be going very slowly into the mitochondria, but if you have STAR, it suddenly starts to push it to the mitochondria, where you have got a whole process in which you produce these steroid hormones from that perspective, which are released. So abnormalities in this particular in this particular transporter, so to speak, will result in a unique pattern of hormonal defects. So what are the characteristic effects of STAR defect on the fetal adrenal, the mature adrenal, the testis, and the ovaries? So typically it is a double hit model. More you work, more you get destroyed. Myasthenia gravis, the more your muscles work, the early they get tired. So now you need to understand that which part will work more. Fetal adrenal, yes, no? It is very active. So fetal adrenal is destroyed. What about the actual adrenal, which the baby will now do work? Yes. So the only time in the fetal axis when this is active is 8 to 12 weeks. When you produce some cortisol, otherwise the cortisol is very low. At term, you start producing more. So till term, this adrenal will be completely safe because it is not very active. But after term, you will have a double hit model. The first hit is okay, your rate of steroidogenesis becomes around 15-17% because transport is less. Then this cholesterol tends to accumulate in the cell, it destroys the cell, and that's why the double hit model is. So what will be the typical age of presentation of star defect? 1 year, 2 years. So it's much later compared to other forms of CAH. And some non-classical forms of star may just present to you with what is known as quote-unquote isolated glucocorticoid deficiency. Like the child whom we have, who behaved more like we're thinking of ALD as a possibility because there was a sibling also involved, and he was found to have a star defect. So now we are seeing star defect in much minor forms of isolated glucocorticoid deficiency as well. What about testis? So testis is it active or not in the fetal period? Very active. So testis will be destroyed. So your testis may actually be destroyed very early. So if your testis is destroyed, and we talk about destroyed, which part of testis, Sertoli or Leydig? Sertoli cell will be affected. Then you said much more.
Which one is much more effective?
Which is, so Sertoli will not be affected because that is totally independent. Only the Leydig part will be affected. So your androgen production will be defective. And if the androgen production is defective before 8 weeks, you will have complete DSD. You will have a female appearance, but will you have uterus or not? Complete star defect because AMH is working. If you have a defect later on, you will have DSD. If you have even later on, you may just have micropenis, but mostly they will present with DSD with complete reversal. What about ovaries?
Not active till birth.
So
there will be no effect on ovaries, but later on puberty during that it will be right.
So will they have pubertal onset or not?
They may have a delayed onset of puberty.
Why delayed?
Because in the puberty there is activation of this enzymes and production of the.
So the unique part about female reproduction is that every time you have got a new oocyte which is being recruited from that regards. So in that regard, if you have a new oocyte which is recruited every time, you will have damage only to that particular oocyte. So they will produce some amount of estrogen, but by the time you have got this mid-ovulatory surge, that oocyte whole process will go off. So you will have some breast development, but you will not progress subsequently. So it will not be completely zero puberty. There will be a stalled puberty sort of a thing, which will happen, while testis would have completely gone by the time of birth, it will be gone. So 4-month-old girl with failure to thrive, Vibha, 3.6 kg, birth was 2.8 kg. There is hyponatremia and hyperkalemia, 17 OHP. Okay. Kon Abhijit. 17 OHP is one. Gonads were basically palpable in that perspective. So what are you thinking here? This is a girl child who has hyponatremia and hyperkalemia, and gonads are palpable. So what is it? So XYDSD with a complete reversal. Yeah.
There is a hyponatremia, but when the 17 level is very low as compared to the CH. So this is definitely not CH, but it could be star where the 17 levels are not very.
So if you look at our approach when we talk about a neonatal salt wasting, we say if they have an atypical genitalia which is present, so this goes in that lines. And then if you have a hyponatremia, hyperkalemia with atypical genitalia, and you have got a 17 OHP which is low, you are thinking of star or SCC defect. Can this be 3 beta HSD?
Not that much low, or there could be DSD, but not complete reversal.
So your 17 OHP will be much higher in that scenario. So here the 17 OHP, though this is the classical case of star defect. Ultrasound showed a large adrenals, and this was suggestive of a star defect.